magnitude of the problem. See, this is the leading cause of the end-stage renal disease. I told you the two reasons for the end-stage renal disease. Those people who are preparing for the hemodialysis or the transplantation. Once you are saying that end-stage renal disease means GFR less than the 15. So according to the GFR, you divide the CKD into the 5 grades. Grade 1, GFR more than 90. Grade 2, GFR between 60 and 90. Grade 3, GFR between 30 and 60. Grade 4, GFR between 15 and 30. Less than the 15 is end-stage kidney disease or end-stage renal disease. So for all the people of the end-stage renal disease, when the GFR is less than 15, only 2 options are available. That is the renal replacement. One is transplantation. The second one is the dialysis. Again, the dialysis of the 2 types, hemodialysis and peritoneal dialysis. So once you say that the GFR is less than 15 and you are naming it as an ESRD, so the only 2 options to the patient is to go for the dialysis or the transplantation. Okay. So the leading cause of the non-traumatic lower limb amputation. So on the road, if you see any amputated fellow, there are only 2 reasons in India. One is traumatic amputation. The second one is a diabetic foot ulcer and amputation. So these are very common. So amputation. So to avoid the amputations, we have to give a lot of respect to the peripheral vascular disease and the feet. The foot care is very important. So the foot in the diabetes is much more important than the face. So we have to give a lot of the care in the foot. So about the blisters, about the interdigital areas, and then the dryness of the foot has to be avoided, and the barefoot walking has to be avoided. So these are the tips to see that these fellows won't get the ulcers. Once they get the ulcers, there are the 3 types: neuropathic ulcer, vascular ulcer, or combination of the neuropathic and the vascular. And then the treatment varies from the etiology. And then one of the leading causes are the preventable blindness. Already I told you, the cataract is the one thing and the diabetic retinopathy is the another one. Major risk factor for the coronary artery disease and the cerebrovascular disease. The most common cause of death in type 2 diabetes in India is myocardial infarction or a vascular death. So most of the type 2 diabetes, they die in the hands of the cardiologist. Even though they are having the renal failure, they die in the hands of the cardiologist. Because of the incidence of the early myocardial infarction or sudden cardiac death or autonomic dysfunction leading to the tachyarrhythmias, leading to the death. So this is very, very important. So once the patient diagnoses the diabetes means, we have to see that these people should live for the long period as far as the vascular ill health is concerned. Diabetes means vascular ill health. So you have to give the vascular protective drugs in most of the type 2 diabetes who are at risk of getting the vascular diseases, say elderly individuals, smokers, diabetes plus hypertension, diabetes plus dyslipidemia, diabetes with a strong family history. So some family member died, male, before the 45 years of the age group, female, less than the 55 years of the age group in the family. That means the vascular disease runs in the families. So you have to give the vascular protective drugs like the statins, high dose statins, okay, aspirin in some population, clopidogrel in some population, prasugrel in some population, or cilastagen in some population. So these are the vascular protective drugs. And the most important vascular protective drug is cessation of the smoking. Smoking will aggravate the atherosclerosis. Smoking will aggravate the endothelial dysfunction. ED, endothelial dysfunction means ED. There are the 2 EDs in diabetes. One is endothelial dysfunction. The second one is a secret complication. That is erectile dysfunction. So the erectile dysfunction and endothelial dysfunction, these 2 are very common in the diabetic individuals. So in that way, so see that all the diabetes should live for the longer period. So to give him a good long period of health, so definitely you have to protect the vessels. So vascular protection, you have to see the risk factors of the vascular diseases and then act accordingly. So worldwide, more than 537 million adults suffer from the diabetes. These are the wrong numbers. So the recent number, India study is our president Nandakishore saying that 10 crores is right. 10.4 crores is the number of the type 2 diabetes in India right now. And most unfortunate thing is 13 crores are pre-diabetics in India right now. So if you combine the pre-diabetes and the diabetes, that means dysglycemia is about 25 crores out of 140 crores. Imagine the presence of the dysglycemia in our Indian patients. So you are all will be very, very happy in the near future if you start practicing as a diabetologist, because you get lot of the people with the diabetes. So you are not at all a competitor to me, or you are not at all a competitor to any physician or an endocrinologist or anyone, because in the society what we are all seeing is the tip of the iceberg. So we are seeing just 10 to 15% of the diabetic patients in the society. So don't think that I am a MBBS fellow, or I am an OBC fellow, or I am a urologist, or I am a gastroenterologist, or I am an OB, or an orthopedic surgeon, and not treating the diabetes. Diabetes is your disease. So the patent is 100% to you only. So please see that diabetes should be treated by all of you. If you have any doubts, I am here to help you. Okay. So from tomorrow onwards, you see that diabetes should get a good care from all of your pens. These are the complications in India. You all know the different complications. The most common complication in India in diabetes is the neuropathy. See the coronary artery disease, 21.4%. Peripheral vascular disease about 6.3%. Retinopathy about 17.6%. Don't remember these figures, but one thing is very clear. See the foot, 26.1%. Neuropathy. See the heart, 21.4%. See, so the lot of the people with the more morbidity is the neuropathy, and more mortality is the cardiac. So both are very common in our diabetic individuals, both the neuropathy as well as the ischemic heart disease. So the type 2 diabetes comprises 85 to 90% of all cases of the diabetes in India. So some countries like Scotland, they have a lot of the type 1 diabetes. Whereas in India, more of the type 2 diabetes to the tune of about 90%. See, explosive increase in the prevalence of the type 2 diabetes in the developing countries like India. A tsunami proposition, explosive proposition. So the figures are changing very fast. Very fast. Just 2 years ago, it was about 7.5 crores. Now it is about 10.3 crores. Maybe after 5 years, the maybe 20 to 25 crores. And the pre-diabetes maybe 30 crores. So that means 50 to 60 crores of the Indians are the diabetics by the time you are really interested to do the practice of the diabetology. Okay. So the increase in the number is an explosive increase, like your undergraduate seats. Steady increase in the prevalence of the type 2 diabetes in the developed countries. See, the developed countries, it is a steady increase. Whereas in India, it is an explosive increase. The same thing happens to the conversion of the pre-diabetes to the diabetes also. See, I told you that there are about 13 crores of the Indians are having the pre-diabetes. Do you know the conversion rate in India? Pre-diabetes to the diabetes? It is about 80.5%. So today's pre-diabetic is tomorrow's your diabetic individual. Whereas in Western population in the US, the conversion is just 12.4%. Today's pre-diabetic, there are only 12.5% chances of turning to the diabetic in the near future. Whereas in India, 80%. 80%. So the pre-diabetic, what is the treatment for the pre-diabetics? Not the drugs. Good, lifestyle measures. But no one follows the lifestyle measures in India. So junk foods, fast foods, so late night sleeps, sleep disturbances, see high calorie diet, obesity, a strong family history. So these are the important reasons to to convert more and more sugar and more insulin resistance and more hepatic glucose output, leading to diabetes. Okay. So this is a steady increase there. Here is this explosive increase. And type 1 diabetes is also increasing steadily in the developed countries. So earlier, no, the type 1 diabetes is not that common in Indian population. But last 4 years or 5 years, I am seeing more of the type 1 diabetes also. So last week I have seen 4 months child, type 1 diabetes. So just 2 days ago, I have seen one fellow with 6 years, 8 years, 9 years. So the very common type 1 diabetes right now in the society. Maybe because of your maybe viral insult to the pancreas, or maybe a genetic insult to the pancreas, leading to the insulinitis, insulinopenia, and then the type 1 diabetes, and then the lifelong insulin. Once your diagnosis is type 1 diabetes, the treatment is simple, insulin, to say. How long? Lifelong. But it's very difficult to give a correct dose of the insulin, to keep the HbA1c around 6.5 to 7. So very difficult. So most of these type 1 diabetes, now once you're diagnosed with type 1 diabetes, if you follow them, mostly the people live for about 15 years or 20 years. So I have seen nearly 85 to 90 cases of the type 1 diabetes. No one touched beyond the 20 years of their life of type 1 diabetes. So today's diabetic, type 1 diabetes, after 5 years, he will develop 1 or 2 attacks of the DKA. And then after 7 years or 8 years, you develop the non-proliferative diabetic retinopathy. And after 11 years or 10 years, they develop the nephropathy, and then develop the CKD, and then they have the dialysis, and then the massive myocardial infarction, sudden cardiac death, and then out. So they rarely seen beyond the 20 or 25 years of the diabetic life in type 1 diabetes. That is not the case in the type 2 diabetes. So type 2 diabetes, we can give 100% a normal lifespan. Now the normal lifespan is 80 plus. So I can guarantee it 80 plus for all the type 2 diabetes, provided if you diagnose early and you see the complications early, etc. etc. But the type 1 diabetes is very difficult because their average HbA1c is beyond 10 in type 1 diabetes. It is very difficult to reach the figure of 6.5 or the 7 in type 1 diabetes because of the budgets, because of the pizzas, because of the SRMT malls, because of these other things. Okay, so it is very difficult for the kids to keep the HbA1c at 6.5 the 7. And once the HbA1c is beyond 9 and the 10, we are inviting the complications. So the most important complication in the type 1 diabetes is retinopathy and nephropathy. So out. Okay, so this is a very, very important. So, and don't think that type 1 diabetes occurs in children only. So the most important take home point from today's talk is type 1 diabetes can occur at any age group. I have seen 3 cases at the age of 70 plus. Diabetics, not type 2 diabetes, type 1 diabetes. So 3 months ago, I have seen one executive engineer, superintendent engineer, lost his body weight 18 kgs in a span of 2 months with polyuria, polyphagia, polydipsia. Urine sugar 4 plus, ketone bodies 3 plus, blood sugar 500, HbA1c 14%, weight loss 18 kg, 16 kgs, GAD65 positive, C-peptide very, very low, and your diagnosis type 1 diabetes. At the age of retired fellow, retired superintendent engineer, at the age of 70 plus. So it's a type 1 diabetes. What treatment you have to advise him? Insulin. How long? Till his death. Good. So it is not type 2 diabetes. See, don't think that type 1 diabetes means only children, kids, and all the diabetes you see in the adults is the type 2 diabetes. Now the scenario has changed. The same thing happens to the type 2 diabetes also. Okay, I have seen one fellow in our in the same campus, one employee here in our Ramkoja, child aged about 12 years, got diabetes. So usually 12 years seen by the pediatric individuals. So the pediatrician is diagnosed as the type 1 diabetes, started the insulin therapy. Okay, she is getting frequent hypoglycemias. And then after 6 months or 6 visits or the 7 visits to the pediatrician, they approached me. When I see her, I have seen the beautiful acanthosis nigricans on the nape of the neck. What you mean by the acanthosis nigricans? A velvety appearance. So that is a sign of insulin resistance. So insulin resistance is seen in type 1 diabetes or type 2 diabetes? Type 2 diabetes. Then I stopped insulin. I started on the metformin. No hypoglycemias. She is doing very well. Now she is in the class of maybe intermediate first year. Now she is about 16 or 17 years. See, last 5 years, no hypoglycemia, doing well. Around HbA1c around 6.5 and the 7. So the earlier the diagnosis of type 1 diabetes because age 12 years, diabetes, type 1 diabetes. So that means that early onset of the type 2 diabetes is also common nowadays in India. Type 2 diabetes early onset is common in India. In the same way, type 1 diabetes occurring in the elderly individuals is also common in India. So don't think that because of the age factor, don't diagnose the diabetes as the type 1 or the type 2 diabetes. Okay. So see the markers of insulin resistance like acanthosis nigricans or the skin tags or abdominal adiposity or chubby or more overweight. Okay. More than the normal BMI. So you always think that these fellows could be a case of early onset of the type 2 diabetes. And if you are in a doubt in such individuals, send the investigations for 2 tests. One is C-peptide. The second one is GAD65 antibodies. C-peptide means your insulin GAD65 antibodies. GAD, GAD65 antibodies or islet cell antibodies or pancreatic antibodies. There are very costly investigations just to be sent only for the GAD65 antibodies. So that will be the positive. That means vasculitis is there. Okay. Immunological insult is there. And C-peptide indicates your endogenous insulin production. What happens in type 1 diabetes? Is there any endogenous insulin production? No. So what will happen to your C-peptide level? Low or high? Low. So that is type 1 diabetes. So you send the blood, C-peptide is very low, GAD65 is positive, you are in a doubt clinically whether type 1 or type 2 diabetes. The result is C-peptide low, GAD65 positive. What is the diagnosis? Good, type 1 diabetes. You are in a doubt clinically whether it's type 1 diabetes or type 2 diabetes. Now the C-peptide is very high. GAD65 antibodies are negative. So what is the type of the diabetes you are seeing? Type 2 diabetes. Type 2 diabetes. So that is how you have to see when you are in a doubt. So see these, send these two investigations and then see whether the patient is a type 1 diabetes or the type 2 diabetes. Other forms of the diabetes are rare. Other forms are mostly a pancreatic diabetes. Okay. So young fellow, maybe from the Kerala or the East Godavari or even in the Andhra also, we are seeing some cases with recurrent abdominal pain. Recurrent abdominal pain. Lean. Age is somewhere between 15 to 30 or 35 or 40 years of the age group. Recurrent abdominal pain. Steatorrhea. So greasy, oily stools. Okay. And then the diabetes. And the diabetes is uncontrolled, very high. But ketosis is resistant. So even though the blood sugars are very high for the last 3 months or 6 months, but if you see the urine ketone body is negative. So the people is not going into the DKA, unlike your type 1 diabetes. Once you diagnose the type 1 diabetes, you don't introduce the insulin. Within 10 days or the 15 days or 1 month, they will land up with the severe dehydration and with the Kussmaul's respiration and in the casualty. And the ketone bodies will be positive and you are diagnosed DKA. So that will not be happen in your pancreatic diabetes. So the pancreatic fibrocalculous pancreatic diabetes. So these people have the recurrent abdominal pain, a steatorrhea, a lean individual, diabetes, ketosis resistant, high blood sugars, and from the tropical country, mostly in India, mostly from the Kerala. So this is about the, he told that pancreas type 3C. So you have the type 1, you have the type 2, you have type 1.5, you have the type 3 and also 3C. So already we discussed the type 1 and type 2 and Arun told type 3C, that is your pancreatogenic diabetes. And what about the two other types? Type 1.5 and type 3. Type 1.5 is LADA. So LADA, latent autoimmune diabetes in the adults. So they present as the type 2 diabetes initially, and within a short time, they convert as the type 1 diabetes. So initially they present as the type 2 diabetes. And within 6 months or the 1 year, so they almost behave like the type 1 diabetes. So that is because of the autoimmune destruction. So this autoimmune destruction is not that speed when compared to the type 1 diabetes. This is a slow onset of the auto destruction. So that is the type 1.5. That is a LADA. What is type 3? Type 3 is elderly diabetics with Alzheimer's disease. Okay. So type 1 you know, type 2 you know, type 1.5 is LADA. They present like the type 2 diabetes initially and then convert to the type 1 diabetes. And then type 3 is elderly diabetes with Alzheimer's. Type 3C is pancreatogenic diabetes. And as Arun saying that malignancy is very common in even the diabetics also. So if you see the diabetes and the non-diabetes individuals, diabetes are at high risk of getting the malignancies. Not only your pancreatic malignancy, total gut malignancy. So the gut malignancy, colon malignancies, even the breast malignancy, endometrial carcinoma, hepatic carcinoma, okay, lymphoma, leukemia. So these are all very, very common in type 2 diabetics individuals because diabetes means more chances of having the malignancies also. But some reasons, prostatic malignancy is not that common in diabetic individuals. The reasons we don't know that. Prostatic malignancy is not that common in diabetic individuals when compared to the other malignancies. And one marker to know whether the patient is having the pancreatic carcinoma or not, I think 19.9. CA 19.9 is the marker to detect the pancreatic malignancy and alpha fetoprotein for your hepatic malignancies. So type 2 diabetes in the developed countries, a disease of the middle and the old age. See in the Western population, so diabetes means at the time of their retirement. So the average age they get the type 2 diabetes is 50 plus. Okay. So associated, see they say the middle and old age. Middle age means more than the 50, old age means more than the 70. Associated with the overweight and the obesity. Worrying trend is increasing the type 2 diabetes in the children also. That is the developed countries. What about the India? See the Indian diabetics are totally different from the Western diabetics. Occurs a decade earlier than in the West. I think in my experience not a decade, 2 or 3 decades earlier. So see at the age of 12 years type 2 diabetes. At the age of 25, you are seeing a lot of the people. At the 30, 40, because most of your classmates or your friends are diabetes by this time. So almost at 2 decades or 3 decades earlier to the Western population, we are getting it. That is the most important occurrence in the diabetes. Occurs even in the non-obese individuals. The lean diabetes is common in India. So India type 2 diabetes are divided into 3 groups. A lean type 2 diabetes, normal body weight type 2 diabetes, and overweight or obese type 2 diabetes. So you all know that overweight and obesity, because of the insulin resistance, they are getting the diabetes. Why? And normal body weight people are getting the diabetes. Why the lean diabetics are getting the type 2 diabetes? So maybe because of the genetical transposition. Occasionally seen in the children also, sometimes, although less commonly than in the West. More prone to develop the cardiovascular disease. Here the most common cause death of cause is myocardial infarction. Some studies suggest lower risk of the microvascular disease, but I don't think that microvascular disease is also very common in our Indian population, because all the nephrologists are living on diabetes only, diabetic kidney disease. Most of the retina specialists, without the diabetes, there is no role of the retina surgeon. All the retina surgeons means only diabetic retinopathy, etc. only. Okay. So this is the very common. So even the microvascular disease, these 3 only: neuropathies, nephropathies, and retinopathies. Very common in Indian population. So these are the top 5 countries diabetes burden. China number 1, India 74, not 74 right now. It is about 10.8 now. 10 crores right now. Now the Pakistan is the number 3, United States number 4, and Indonesia number 5. So these are the top 5 countries in the world with highest number of the diabetics. సార్ మారిపోద్ది కృష్ణమోహన్ గారు, మీరు తీసే లోపల ఇంకా నంబర్ చేంజ్ అయిపోతాయి. Okay. See, this is the prevalence of the diabetes. Now the Pakistan is the highest prevalence, 30.5. Even India, prevalence is different from the percentage, sir. Yeah. In the population. So in India, the highest prevalence is in Hyderabad. Diabetes is concerned, 27.5%. Hyderabad, because of the 2 factors. One is biryani, Paradise biryani. The second one is Karachi bakery. Karachi bakery. ఇప్పుడు మన ఎయిర్పోర్ట్లు అంతే కదా, కరాచీ బేకరీ చాలా ఫేమస్ కదా. అవన్నీ యాడెడ్. The two important epidemiological factors to cause more and more prevalence of the diabetes in Hyderabad is because of the biryani and bakery. Okay. So whereas in Calcutta, even the figures are much higher in Calcutta, the population wise, but they are having the less number of the cardiac deaths in Calcutta. Calcutta is having about 18 cath labs. Whole Calcutta is having only 18 cath labs, whereas Hyderabad is having 160 or 170 cath labs. Imagine. So why less number of the cardiac deaths in Calcutta? Because of the fish, omega-3 fatty acids. So their fish is 100%. All people, even the Brahmins. So Jalposhpam, they say that Pranab Mukherjee, ex-president, his favorite dish is fish only. So they eat in the breakfast, they eat in the lunch, they eat in the dinner also. So without fish, no dining. So because of this omega-3 fatty, even though they take a lot of rasgullas. See, the Calcutta means more of rasgullas, sweets. So in spite of the more sweets, they are taking the equal amount of the fish, which contains omega-3 fatty acids, protecting them to not to have the cardiac events. See, these are the epidemiological data. So we should learn these epidemiological data. So don't take much of the biryanis and the bakery items, which are very, very dangerous for our vascular health. See, these are all the different figures. So the rising prevalence, high. So the green is the less. See, South India, red, 12% and above is the red. Okay. So your Andhra Pradesh, your Telangana, Tamil Nadu, Karnataka, Pondicherry. So you are all having the highest prevalence of the diabetes in Indian population. So this is the recent ICMR study. Total samples is nearly 1.2 lakhs. Overall prevalence. The burden of diabetes and pre-diabetes in India is larger than the previously estimated. Okay. As per the ICMR India study, there are about 10.1 crores individuals with diabetes and 13 crores with the pre-diabetes in India as of 2021. Imagine now 25. Okay. So maybe 13 crores or the 14 crores, and here maybe 18 or 20 crores of the pre-diabetics. A wide variation in the prevalence of the diabetes between states, particularly in the rural areas. Prevalence is uniformly high in the urban areas. See, in India, at least in South India, there is not much difference between the rural India and the urban India, unlike in our North India. Whereas here, urbanization of the rural India is very common in our Indian population. You go to Maredmilli, you get all the things here. Whatever the food items you have it in Kakinada, you will have it in Maredmilli, in Rajolu. So, urbanization of the rural India is a very, very common. So that is the reason, because of the junk foods, lot of the street foods, junk foods causing lot of ill health to our population. So that is the reason for the increased incidence of the diabetes. Okay. Prevalence of pre-diabetes is uniformly high across the states in both rural and urban areas. See, first question. Nearly 50% of the people with diabetes in India are undiagnosed. Okay. So that depends on the place to the place. So there is a national program, thanks to the central government. National program for prevention and control of the non-communicable diseases. Okay. So what are they? Control of cancer, diabetes, cardiovascular diseases, and the strokes. Promoting a healthy lifestyle through the massive health education and mass media efforts. Universal screening of the adults. Setting up of NCD clinics. Development of the trained manpower and strengthening of the tertiary care facilities. So these are all the national programs. So what about the role of you people as a primary care physician? It's a large problem, diabetes, for the government to tackle on its own. So we do not have the sufficient trained specialists, either endocrinologists or the physicians, to deal with the burgeoning epidemic. So hence it is important that every doctor like you be familiar with the basics of the diabetes management. So that is my goal. Why I am very much interested in the diabetes teaching is this is the best slide from my heart. See, it is very much important that every general practitioner or any specialist or a super specialist be familiar with the basics of the diabetes management. See, the epidemic is spreading, okay, from Hyderabad to this place in the UK, Uppadu Kottapalli to Maredmilli, okay, to smaller towns and even to the villages also. So in all these places, the primary care physician has a major role in identifying and managing the diabetes and making prompt referral if any person with the diabetes has any complications. See, we are seeing a lot of the diabetes dying unnecessarily because of their poor referrals. So whenever the patient is having the pain in the abdomen region, they always thought that it is because of the gastritis. Taking one Happy D or the Pantop or the Rantic or Randraft or Gelusil. Okay. And then making these people not to go to the doctor at a specialist early time. So by the time they reach the doctor, most of the people they are dying. Even though they are living, so they are getting the early onset of the heart failures because of the necrotized myocardium. So don't think that chest pain is a cause of is a symptom of the myocardial infarction. You should understand the angina equivalents. What are the angina equivalents? Dyspnea, especially in the diabetic individuals. I say that dyspnea is a much more important symptom of the heart attack in a diabetic individuals than the chest pain. So pain in the interdigital areas, pain in the epigastric region, pain in the jaws, pain in the left hand, pain in the left shoulder, or pain in the interscapular area. So these are all the places where this pain is considered to be angina equivalent. So you see that, so get an ECG done. So even though the first ECG is the normal, don't discharge the patient. Observe him. Get another ECG after 1 hour or the 2 hours. See the serial changes. So the ECG could be the normal in most of the cases of the early myocardial infarction. So it takes some more time to see your ST changes or your QS complexes, etc. Okay. So normal ECG doesn't mean that the heart is normal. Nearly 20% of the adult patients in the general hospital OPD will have the diabetes. So that depends on the department. Suppose it is the OBG pregnancy. I think right now about 15 to 20% is a right answer. Maybe 25% also. Suppose if you see the general medicine, maybe 50 to 60% of the diabetics. Okay. So, but more than half of these patients are unaware that they have the disorder. The primary care physician like you has a unique opportunity to identify and treat these cases at the earliest possible stage. A state of the blissful ignorance or diabetes awareness in India. 43% of the Indians have ever heard of the diabetes. 50% do not know that diabetes can lead to the organ complications. 80% do not know the risk factors for the diabetes. 50% do not know that diabetes can be prevented. So big thanks to our ETV, Suki Baba, etc., etc. So every day you have a lot of the health talks on the TV media and also in the papers also. So you have to spread all these messages. So to educate the people that diabetes is a very common in the society and the early diagnosis is very, very important. The primary care physician has a major role in educating his patients and their relatives about the diabetes so that they seek the detection and care early. So that is the beauty of the education. So the medical education has a major role, especially in the non-communicable diseases like diabetes, to detect the diabetes at an early time. So that's what the Jocelyn said. You know who is Jocelyn? Father of diabetology, Professor Jocelyn. He started an exclusive diabetic hospital in 1919 in US. So what drug was available at that time? 1919? No drug. Insulin is the first drug. 21. 23 they got the Nobel Prize. Okay. So 2 years before the introduction of the insulin, he started an exclusive diabetes hospital in US. He is Jocelyn. Professor Jocelyn. Jocelyn Medical Center is one of the biggest diabetic center in the world. So he lived nearly 90 years. Okay. So at the age of 90 or 80, 90 years, someone asked that, you please talk about the diabetes in one word. He said that the one who knows diabetes most lives longest. So that is his ultimate sentence. About his, say about 70 or 75 years of experience in the diabetes, he said that education is the most important in diabetes. The one means he may be a doctor or a nurse or a non-doctor, anyone in the world. The one who knows diabetes most lives longest. So that is the education, importance of the education in a diabetic individual. So these words are from the Jocelyn's, Professor Jocelyn, father of modern diabetology, once said that the one who knows diabetes most lives longest. So everyone should know diabetes, whether he is a diabetic or a non-diabetic, to live long, because once they know the diabetes, they know all the symptomatology of the diabetes, how to detect the diabetes, what are all the tests to be done for the detection of the diabetes, what are all the tests to be done to detect the early complications of the diabetes, and what is the treatment aspects, modalities, etc. So that if they apply them, so definitely they live long period. No consensus on the glycemic targets and the guidelines among the doctors. Okay. Management of the lipids and the blood pressure is suboptimal. So this is diabetes means don't ignore the blood pressure and the cholesterol also. See here, ABC is very important. Not only the A, here is saying that C, lipids means C, blood pressure means B. So the both management of the B and C is suboptimal. So you have to control the blood pressure, keep the blood pressure at goal, and also cholesterol at goal. What are the 5 parameters of LP? Ni parent amma? Huh? Sri Lakshmi. What are the 5 parameters of LP? What is LP? Lipid profile for a diabetologist. Okay. For a neurologist? For a neurologist? Lumbar puncture. Okay. So for us it is a lipid profile. Okay. So what are the 5 parameters of LP? LDL. Only Sri Lakshmi should answer. LDL, HDL, VLDL, triglycerides. Very good. Don't say total serum cholesterol. Serum cholesterol. Okay. So now tell me the targets of the different factors. So cholesterol. So triglycerides less than 150, HDL more than 40 in males, more than 50 in the females, and serum cholesterol less than 200. See, diabetics are at high risk individuals. Okay. So your goal should be less than 70. Even in some people, even less than 35 is, so that is the LDL. VLD is nothing but 1/5 of the triglycerides. Okay. So when the triglyceride is 150, your VLDL is maybe 30 or 35. Okay. Cholesterol, serum cholesterol minus HDL. Serum cholesterol minus HDL. Suppose serum cholesterol 200, HDL 40. So what is your non-HDL? 160. Okay. Adi non-HDL cholesterol, you have to get it from tomorrow onwards. You please get non-HDL from your LP report. Non-HDL is nothing but serum cholesterol minus HDL. So that is one point. And the second most important point of non-HDL is, what is the target of non-HDL? The target is 30 plus your LDL target. LP means lipid profile for us, for a diabetologist. LP don't give importance to the VLDL. VLDL is just 1/5 of the triglycerides. So the fifth parameter of your LP is serum cholesterol minus HDL, that is non-HDL. Your non-HDL cell target is 30 plus your LDL target. Suppose your LDL target is 100. Okay, then the non-HDL cholesterol target is 130. See, here management of the lipids and the blood pressure is suboptimal in Indian population. That's true. If you check the blood pressure, most of the times all the diabetes, the blood pressure is 140 by 90, 150 by 100, 160 by 100. So that's suboptimal. You check the LP, the serum cholesterol is 230, HDL is say 28, 30. That is another important parameter of our Indian diabetics. See, I told you the Indian diabetes are different from the Western population. And most important Indian parameter abnormality is HDL-free cholesterol. 80% of our Indian population HDL is less than the 40 in the males, less than the 50 in the females. I don't know what is your HDL. You see the LP tomorrow, and your HDL most of the times is less than 40 in the males and less than 50 in the females. This is the most important protective parameter to against the atherosclerosis. So, for example, for me, if the HDL-C cholesterol is 50, even though my LDL is 100 or 130, I may not have a much atherosclerosis because of the protectiveness of my high HDL. On the other hand, my LDL is 80 and my HDL is 28, then I am at a risk of getting the atherosclerotic event because of the two reasons. One is my protective HDL is low and then my LDL is more than the normal. So double risk or double negative points. So in a single word, keep all the people's HDL at a higher level to have a more protection. So now tell me, most of the Indians are having the low HDL. How to improve your HDL? What are the parameters to improve the HDL? One is exercise. Number two is alcohol. Alcohol, not to cause the chronic pancreatitis. See, we don't advise the alcoholism to improve your HDL. But to improve the HDL, exercise will help you. Exercise will help you. There are certain drugs like niacin, but that is not palatable. Lot of the gastrointestinal side effects of the niacin. Niacin is a beautiful drug to improve your HDL, but the palatability is very, very poor. So even though you prescribe the low dose of the niacin, most of the people, they complain with the abdominal cramps and the nausea, vomitings, etc. So that is the reason the only option left is only physical activity. Physical activity. Now tell me, is the 150 minutes a week or more than that for our Indian population? Physical activity. If you see the Western population, Western textbooks, so what they say, 30 minutes a day. Okay, 5 days a week. So 30 into 5, 150. 150 minutes a week. Absolutely wrong for our Indian diabetics. Because we are having more insulin resistance. We are having more abdominal adiposity. So for us, at least 60 minutes a day, 7 by 7. Not 5 by 7. 7 by 7. Okay? 365 by 365. So that is how we have to keep your HDL above your required level. Otherwise, it's very, very difficult. Okay. So another important point for us is Indian diabetics is HDL is at a lower level. To improve the HDL, the only option is physical activity. For those people who are chronic alcoholics, they can't avoid it. Then we say that moderation of the alcohol, maybe 1 or 2 packs a day, etc. That is all if and buts. But in general, no alcoholism, because alcohol is again is a J-shaped relationship as far as the diabetes is concerned. The situation can only be improved by training the primary care physicians who treat most of the diabetic patients in this country. So the primary care, these 3 A's: acceptability, good for you, your own patients, and availability and affordability. So aims at creating a cadre of trained primary care physicians to tackle the diabetes epidemic in India. Now the normal glucose metabolism. Dietary carbohydrates is the main source of the energy. See, again, unfortunately, we are taking more of the carbohydrates, almost 70 to 80%. Even if you take the rural India, maybe 80 to 90% carbohydrates. So that is the one reason for the increased incidence of the diabetes in Indian population. Okay. See how many, see the salient features of our Indian diabetics. So incidence is very high because of the high dietary carbohydrate. Simple sugars like glucose, sucrose, lactose, and complex carbohydrates like starch and the glycogen. So the two shops are very common in any junction. 2 shops. One shop is sweet shop, another one is wine shop. Huh? Tea. Okay. Tea time. See the sweet shops, very, very high in number. Everywhere you see the sweet shop. You see the consumption of the sweets in our population is a very high. That could be another reason for the increased incidence of the diabetes. Not only the sweets. Sweet contains a lot of the fat also. Okay. So the fat content is also will be very high. So that means more atherosclerosis, more diabetes, etc. See, the complex carbohydrates have to be broken down to the monosaccharides if they are to be absorbed. So that is the reason we advise more of the complex carbohydrates rather than the simple sugars. So simple sugars absorption is very quick. Your postprandial blood sugar will go up. If you give the complex carbohydrates, they take the longer time in the stomach to get the digested and absorbed, so that the blood sugar rise will not be that high when compared to the simple sugars. So our concept is reduce the carbohydrates, reduce the simple sugars, and increase the complex carbohydrates. So this is the dietary carbohydrate, the salivary amylase and the pancreatic amylase, and oligo and the disaccharides, and intestinal disaccharides, brush border enzymes, monosaccharides to the absorbed form. So here you have the drug to use this. So you have the acarbose and now the voglibose. So they act at the level of the intestinal brush borders to reduce the intestinal absorption of the carbohydrate. Okay. So they reduce either fasting blood sugar or postprandial blood sugars. Postprandial only. So don't expect by using the voglibose to reduce your fasting blood sugars. So they have the action only at the level of the intestines only. So intestinal absorption is reduced so that you can have the postprandial reduction, not the fasting blood sugar reduction. So fate of the glucose postprandial state. So entry of the glucose into the skeletal muscles cells is insulin dependent. So the glucose entry into the skeletal muscle is insulin dependent. So I told you the insulin acts at the level of the 3 levels. One is at the liver, muscle, and adipose tissue. So entry into the muscle is facilitated by your insulin. In other cells, uptake takes place along the concentration gradient. Once inside the cell, the glucose is converted to the glucose 6-phosphate by hexokinase or glucokinase enzyme. So once enter into the cell, it is converted to the activated. The glucose is activated to glucose 6-phosphate by the hexokinase. All cells can convert the glucose 6-phosphate into the pyrate, that is the glycolysis. And pyruvate can be converted to the acetyl coenzyme A, which can be used in the synthesis of the fatty acids, are completely broken down to the CO2 and H2O, that is TCA cycle, with the release of the large quantities of the ATP, that is the energy. So in a single word, when the glucose is entered into the cell gets activated and more formation of the ATP. Okay, more energy. So in contracting the muscle, pyruvate is converted to the lactate. In the liver and the skeletal muscle, some of this glucose 6-phosphate is converted to the glycogen, that is called glycogenesis. See, glycogen is the very important one. So that is the storage form of the glucose. Storage form of the glucose is the glycogen. This glycogen is mostly in the muscle and also in the liver. So once you are on the fasting, so what will happen? So the liver glycogen will be converted to the glucose, that is glycogenolysis. In the same way, the glycogen present in the muscle is also converted to the glucose, that is called glycogenolysis. Okay. So, so the storage form of the more the glucose in our body, so that will reach either to the muscle or to the liver, to some extent to the fat cells, adipose tissue, to storage as the glycogen. And when you are on the fast, so this will be converted to the glucose by process called glycogenolysis. So the conversion to the glycogenolysis, the formation of the glycogen is glycogenesis. So the fate of the glucose is the cell. So the glucose, I told you the glucose 6-phosphate. So glycolysis is the pyruvate, or this is a glycogen formation. See, from the pyruvate, you can see the anaerobic and the aerobic cycle, and the fatty acids and the lactates. So that is how the lactic acids or your diabetic ketoacidosis occurs. So more and more free fatty acid reduction will cause more the fatty livers. Adaptation to the fasting, energy stores. Glucose is an obligate metabolic fuel for the brain neurons. So the brain depends only on the glucose. That's what happens in your hypoglycemia. So when the blood glucose is 20 and 30, they are not in a conscious state. They are unconscious. The froth in the mouth, convulsions, altered sensorium, or drowsiness. Okay. So these are all the features of the severe hypoglycemia because of your dysfunction in the neurons, cerebral neurons. So the brain depends only on the glucose. So the brain cannot withstand the hypoglycemia for more than a few minutes, and most of the time they do. That is the reason. Another important take-home point is, don't see that hypoglycemia can occur in the nocturnal period in elderly individuals. So in elderly individuals, keep the blood sugar at a higher level. If you keep the blood sugars close to the normal, at the cost of hypoglycemia. So if they develop the hypoglycemia during the nocturnal time, so they may not recognize the hypoglycemia, and then they die of the severe hypoglycemia. So hypoglycemia is of two types. One is adrenergic hypoglycemia. The second one is neuroglycopenic hypoglycemia. Adrenergic hypoglycemia is a very happy, safe. Because what are the adrenergic symptoms? Palpitations. Okay, sweating, some headache, some tremors. Okay, some try to eat and they are conscious. Once they are conscious, getting the tremors, palpitations, sweating, try to eat. So what they do, as long as they are conscious, they eat by themselves. And then they convert the hypoglycemia into euglycemia. So that is adrenergic symptoms. That is good. The second one is neuroglycopenic hypoglycemia. In neuroglycopenic hypoglycemia, they don't develop the adrenergic symptoms. Suddenly they develop convulsions. Suddenly they fell on the ground. Suddenly they develop the unconsciousness. So this is neuroglycopenic. Which one is dangerous? Neuroglycopenic is dangerous because they can't convert the hypoglycemia into euglycemia by themselves. They need assistance. They need medical aid. So in all the elderly individuals, those living alone, so definitely you have to keep the blood sugars at a higher level. Otherwise, if you introduce the sulfurias or if you give the large doses of the insulin, so definitely you are inviting more and more hypoglycemia, and then sometimes they may die also. So by the time you reach there in an unconscious state, in the dying position, so he is fully sweated. So you blame the heart rather than the glucose. So he must be having a massive myocardial infarction, the profuse sweating, etc. You think that the patient died of acute myocardial infarction or sudden cardiac death. So it is not a sudden cardiac death. It is because of the neuroglycopenic hypoglycemia. So that is very common. Okay. So from tomorrow onwards, for all the elderly individuals, don't keep the blood sugar so tightly, not to invite the hypoglycemia. That is neuroglycopenic hypoglycemia. That is most dangerous one thing. See, in elderly individuals, hypoglycemia is much more dangerous than the hyperglycemia. See, the quality of the life or longevity of the life is very, very important. as far as you to choose the drugs and to keep the blood sugars at target level. Suppose as a patient 30 years, keep the blood sugars at as tight as possible. On the other hand, when the age is 70 plus or 80 plus, so loose control is much more better than the tight control. Okay, loose control and tight control. Tight control for the young individuals, those who are having the high lifespan. Where the short lifespan, elderly individuals, loose control is better than the tight control. So adaptation to the fasting energy stores. Sources of the energy during the fast include glycogen, mainly in the liver and the skeletal muscle, exhausted within 18 hours of the fasting. So even though the people are in the fasting for 14 hours or 15 hours, so happy, both the liver and the muscle will take care of it because of the conversion and giving. And after the 18 hours of the fasting, these two are exhausted. Then starting breakdown of the muscles. So the proteinuria and then the fat cells burned out. Then the ketone bodies will appear. That is the fasting ketone bodies. అందుకే కదా ఏదైనా రాజకీయ నాయకుడు ఫాస్టింగ్ లో ఉంటే ఏం చేస్తుంటారు, కీటోన్ బాడీస్ చూస్తుంటారు. కీటోన్ బాడీస్ నెగిటివ్ వచ్చినా సరే ల్యాబ్ లో పాజిటివ్ అని రాయించేసి సడన్ గా హాస్పిటల్ టర్న్ చేసేస్తారు, అంబులెన్స్ లో ఎక్కించేసి. ఓకే, ఎందుకని ఈస్ గోయింగ్ టు డై బికాస్ ఆఫ్ దిస్ ketosis. So this is ketosis. So first to be exhausted and first to be replenished is the glycogen. And triglycerides, major energy source of the body after 24 hours of the fasting. Mobilized during the prolonged fast, broken down into the fatty acids and the glycerol. Once the fatty acids are convertible, then you will have the ketone bodies. Ketone acids. Okay, acetone, acetate, beta hydroxybutyric acid. So these forms from the free fatty acids. So same thing, glycogen in the liver and the muscle, liver in the 25%, muscle in the 75%, about 18 hours of the fasting. So this is the Cori cycle in the liver. A Cori cycle is a means by which muscle glycogen can be utilized to maintain the blood glucose levels, even though the skeletal muscle cannot by itself release the glucose into the bloodstream. It also helps in providing the glucose to the muscle as a fuel during the contraction. After 24 hours of the fasting, so this is called neoglucogenesis. So here the neoglucogenesis means glucose production from the protein and the fat. In the first 24 hours, it is glycogenolysis. So whatever all the stored glucose in the form of the glycogen is there in the muscle and the liver is converted to the glucose, that is glycogenolysis. Beyond the 24 hours, so then your protein and the fat will be converted to the glucose. This is neoglucogenesis. Production of the glucose from the non-carbohydrate precursors. That means not from your glycogen. Usual substrates here are the lactate, amino acids, alanine, and the glycerol is a part of the fat. So propanol coenzyme A. The main sites here are the liver and the renal cortex. Hormone effects in the fed state. The only hormone involved is the insulin. Here you please remember these functions of the insulin. Insulin promotes glycolysis, promotes glycogenesis, promotes lipogenesis, synthesis of the triglycerides from the fatty acids and the glycerol, promotes protein synthesis, inhibits the neoglucogenesis, glycogenolysis, proteolysis, that is the breakdown of the protein, and lipolysis, that is the breakdown of the lipids. So that is the reason insulin improves the body weight. Improves the body weight. See what happens in the type 1 diabetes. On the day of your diagnosis the type 1 diabetes, they are very lean. Because of the high blood sugars, because of the ketone bodies, you introduce the insulin. So what happens to their body? Weight. So they are gaining the weight. Why they are gaining the weight? Because of these factors. Because they promote the glycogenesis, they promote the lipogenesis, they promote the protein synthesis, and they inhibit all these things. Okay. So for example, you just see that insulin deficiency. So what will happen? Here insulin promotion. What will happen in insulin deficiency? Yes. Reversal. So promotes glycogenesis, lipogenesis? No. There will be lipolysis. So promotes protein synthesis? No. There will be proteolysis. They inhibits? No. They promotes neoglucogenesis, glycogenolysis, proteolysis, and lipolysis. And what happens to their body weight? reduction. So that's what happens in the type 1 diabetes in the early time. Because of the insulin deficiency, they lose body weight, unintentional weight loss. So in clinical medicine, only two conditions with unintentional weight loss. One is type 1 diabetes. The second one is thyroid, hyperthyroidism. Okay. So these two conditions, there will be unintentional weight loss. Fasting, the first hormone response to the fasting involves suppression of the insulin secretion. This is followed by the increased secretion of the counter-regulated hormones like the glucagon. Glucagon and epinephrine are quicker in onset but short lasting. Growth hormone and the cortisol have slower but persistent effects. Net result of these hormonal changes is to increase the endogenous glucose production by means of glycogenolysis and neoglucogenesis, as well as increase the production of the free fatty acids and ketone bodies by the lipolysis. Okay. So these are all the fasting state. Once you are in the fasting state, so once you need the more and more the glucose in the body, so definitely the first response is suppression of the insulin. The second response is hyperglucagonemia, and then there will be hypercortisol, then the hypernephrine, norepinephrine, and the growth hormone. So these four are the counter-regulatory hormones. What are the counter-regulatory hormones to the insulin? So glucagon, cortisol, growth hormone, and epinephrine and norepinephrine. Incretins. Again, a beautiful hormones released by the intestines. Your GLP-1 receptor agonists and GIP. GLP-1 and GIP. These two are the incretin hormones produced from the intestines. These are the hormones derived from the gut epithelium that bind to the surface receptors and the target cells to broadly affect the metabolic physiology. They enhance the insulin production, secretion, and responsiveness. So the more the incretins, more the insulin production. There is a lesser the incretins, the more the chances of diabetes. So we have the incretin enhancers now in the market. You have the GLP-1 and also you have the DP4 enzyme inhibitors. Okay. They increase the islet beta cell mass, slow gastric emptying, suppress the appetite, inhibit the glucagon secretion, and suppress the hepatic glucose production. See the beautiful, these are all the beautiful actions of your incretins. See, beta cell mass. There is no drug which increases your beta cell mass except your incretins. So once you have the good beta cell means you have the good insulin. Once you have the good insulin, the chances of diabetes is less. Then the slow gastric emptying, not the slow gastric emptying. That means your postprandial blood sugar elevation will be slow. So you don't have any postprandial hyperglycemia when there is a slow gastric emptying. Suppress the appetite. So some people will have the binge eating. So 5 bhajis, 10 bhajis, okay, 5 samosas, etc. So these are all of your appetite. More and more appetite and more binge eating. So that suppresses the appetite. That's good because they also act at the level of the brain. You have the appetite center in the hypothalamus, posterior pituitary. They inhibit the glucagon. So the more the glucagon means more the blood sugars, hyperglucagonemia. So that inhibit the glucagon because they also act on the alpha cells and suppress the hepatic glucose production. They also act at the level of the liver. So tell me on how many organs they act? Incretins. 1. Alpha cells. 2. Beta cells. 3. Intestines. Stomach and intestines. Then the 4. Liver. And 5. Brain. See the omnious octet means 8 ways of getting the hyperglycemia. These incretins will act on the 5 out of these 8 ways. So alpha cells, beta cells, intestines, brain, and also the liver. See, this is the beautiful slide. The incretin effect demonstrates the response of the two oral versus the IV glucose. See, the first one is your glucose levels. Oral glucose తీసుకున్నారు, అలాగే IV glucose కూడా ఇచ్చాం. So what about your glucose levels? Both are the same. Either the oral glucose or your IV glucose, the glucose levels in our blood is same. So on the second picture, if you see the incretin effects, oral and the IV glucose. In the oral glucose, you have the high incretin levels when compared to the IV glucose. So that means once you think that you are taking, you want something to be eaten, so immediately it gives signals to the intestines to secrete more and more incretins. Okay, so this incretin effect is good because you are having the more incretin means whenever you eat, so you are taking more of the carbohydrates, 60 to 70% of the carbohydrates. So after the carbohydrates, what will happen to your blood sugars? Post-mortem blood sugars will go up. So because of this incretin effect, so our blood sugar levels are at a lower level because the incretins we have, they act on the beta cell, alpha cells, intestines, etc., etc. Then they keep the blood sugars at a normal level. So because of this poor incretin effect, those people who are having the poor incretin effect, what will happen to their blood sugars? Rise. Okay. Now you have the two types of the drugs. You have the incretin GLP-1 receptor agonists. GLP-1 receptor agonists. The same behave like the GLP-1 receptors. So you have there the parenteral forms and the oral forms are there. Exenatide, liraglutide, and also the semaglutide. Now the oral semaglutide is entered into the market. GLP-1 receptor agonist by brand name Rybelsus. So each tablet is costing about 333 rupees. So per month it is about 10,000 rupees. Okay. So it is available in the 3 milligrams, 7 milligrams, and 14 milligrams. The brand name is Rybelsus Novo. Pharmacological name is oral semaglutide. That semaglutide is GLP-1 receptor agonist. That is incretin. See the role of the incretins in the glucose homeostasis. See the beautiful picture. Ingestion of the food. Okay. So what that gives signals to the GI tract. So in the GI tract, what happens? The release of the gut hormones. What are they? Incretins. Okay. What are the incretins? GLP-1 and the GIP. Here you got the point here. So that GLP, active GLP-1 and GIP will become inactive in the presence of which enzyme? DP4 enzyme. So unfortunately, so whatever the GLP-1 and GIP is produced by our intestines, they are staying for very little time because of the presence of villain. What is the villain name here? DP4 enzyme is the villain. So that villain is making our active GLP-1 and GIP to become inactive within a short period. So now you have the two types of two drugs to tackle this problem. One is you give the GLP-1, which looks like a GLP-1, active GLP-1, but not being destroyed by this DP4 enzyme. That is the robo. So that is what GLP-1 receptor agonists, your liraglutide, exenatide, or your oral semaglutide, they are almost looks like the GLP-1, but not being degraded by your DP4 enzyme, so that your GLP-1 will be at a higher level, so that you will have all the positive effects. Am I clear? Okay. And then second drugs are to block that villain. What is the villain here? D4 enzyme. Suppose you inhibit the D4 enzyme, so what will happen to your active GLP-1? That stay for a longer period, so that you will have all the positive effects. So you know what are all the D4 enzyme inhibitors in the market. What are they? Gliptins. What are the name the gliptins? Sitagliptin, saxagliptin, vildagliptin, linagliptin, teneligliptin. Okay. So these gliptins are available in the market. So they block the D4 enzyme, so that your endogenous insulin GLP-1 will be at a higher level. So am I clear? So incretins is a very, very important hormones produced by the intestines, but unfortunately they are staying for a very little time because of the presence of the D4 enzyme. So to have the positive effects of the GLP-1 in our body, you have analogous, almost like a robo, which does not degrade by the D4 enzyme. They are called the GLP-1 receptor agonists. You have the oral form also available, oral semaglutide. On the other hand, you can also have the D4 enzyme inhibitors, which blocks this enzyme, so that your endogenous GLP-1 will at a higher level. See how they act. They act both on the beta cells and the alpha cells. Okay. 1 and all for your patient here.